Hello everyone! Welcome back to my YouTube channel, the MCL Charge Capture and Coding.
Welcome!
We have already learned about the incision and drainage procedure in Part 1 and the needle aspiration procedure in Part 2 of our 4-part video lecture series presentations on abscess drainage procedure. Full disclosure, the main sources of my lectures are the CMS website, the National Library of Medicine website, and our current CPT 2024 codebook. I will mention or show my other online resources, if any, as we go along with our presentation. And please note that all my lectures are from a billing and coding perspective. Please feel free to pause the video if you need more time to read through the descriptions shown in your screen and hit the play button when you're ready to resume with our lecture presentation. So, now let us begin. Let us first talk about the anatomy and physiology of fluid collections and abscess. When the body develops an infection, depending on the causative organisms, there is the possibility of abscess formation. As part of the body's immune response, the infection may become walled off by the body. These walls allow purulence to accumulate in the form of dead immune cells, infectious organisms, and debris. Fluid collections and abscesses can form almost anywhere in the human body to which there is access by microorganisms, specifically bacteria. Skin and soft tissue is a common site for the development of abscesses. Other common locations involve the sigmoid colon, such as in the case of a diverticular abscess. Additionally, in cases of complicated appendicitis, an abscess can form or the appendix can rupture, forming an abscess in the right lower quadrant. This is in reference to the published article entitled Percutaneous Abscess Drainage in the website of National Library of Medicine. Referencing our current CPT 2024 codebook, Code 10030 describes a bundled service of image-guided fluid collection and drainage from an abscess, hematoma, seroma, lymphocele, or cyst via percutaneous of soft tissue such as the extremity, abdominal wall, or neck, using a catheter. Percutaneous means that the procedure was made, done, or effected through the skin. This code is to be reported for each individual collection that is drained using a separate catheter. This code should not be reported in conjunction with other imaging codes you see on the screen. Code 10030 requires that a drainage catheter be left in place for post-procedure evacuation, not just for the intra-procedure aspiration. An aspiration procedure is different from abscess drainage because a drain is left in place at the conclusion of the procedure. A common procedure in most radiology practices is the utilization of a drain or catheter percutaneously under an imaging guidance. More often, the development of an abscess, regardless of its location in the body, requires further intervention when a simple incision and drainage cannot be performed. Percutaneous drainage can bridge the gap between non-invasive and surgical intervention with minimally invasive image-guided drainage. Please refer to our online reference, Percutaneous Abscess Drainage, through the National Library of Medicine website. The indications for image-guided percutaneous catheter use are as follows: treatment of multiple or multiloculated abscesses, abscesses that may have enteric communication, abscesses that are more than 3 centimeters in size, clinical diagnosis isn't clear, failure of medical therapy, non-compliance with medical therapy. In every procedure, either minor or major procedure, complications are always a possibility and being advised by the physicians to their patients. These site-specific complications can manifest with percutaneous abscess drainage as pain, infection, and bleeding. For those in the billing and coding department who are not familiar with the equipment being used when this procedure is performed, the following are some essential items needed to carry out the surgical drainage successfully, which you will find in your physician's progress notes or operative report, and are not separately billed by the same physician for the same encounter. For image-guided fluid collection and drainage from an abscess, hematoma, seroma, lymphocele, or cyst from a percutaneous visceral such as the kidney, liver, spleen, lung, or mediastinum, using a catheter, report CPT code 49405. For image-guided fluid collection from percutaneous of peritoneal or retroperitoneal collections, report CPT code 49406. Peritoneal, that which relates to the peritoneum, is the serous sac that consists of mesothelium and a thin external layer of irregular connective tissue that lines the abdominopelvic cavity and covers most of the viscera in that location. It forms two sacs, the peritoneal or greater sac and the omental bursa or lesser sac, which are connected by the omental foramen. Retroperitoneal refers to external or posterior to the peritoneum. Here are more parenthetical guidelines for code 49406. For image-guided fluid collection drainage from transvaginal or transrectal of peritoneal or retroperitoneal, report CPT code 49407. Transvaginal means across or through the vagina. Transrectal pertains to passing through or performed by way of the rectum. Please note more parenthetical guidelines for code 49407. In my research, I found this step-by-step percutaneous catheter management of abscess fistula complexes. Please refer to the legends you see in your screen. These describe the functions of white and black arrows. The following are in reference to our example figures and demonstration retrieved from a case study entitled Abscess Fistula Complexes, a Systemic Approach for Percutaneous Catheter Management by authors David Bellard et al., as published in ResearchGate.net. The first figure shows the first step wherein a percutaneous abscess evacuation procedure is performed using two drainage catheters. Here the physician moves to the right in direction of intestinal peristalsis as shown by the white arrow, while the enteric fluid leaks into the inflammatory walled-off abscess cavity as the direction represented by the black arrows. After the percutaneous abscess is evacuated, you see that the abscess cavity has decreased in size. This makes the fistulous tract identifiable by catheter fistulogram. So, the physician now inserts a catheter into the loop at the bowel in the direction of peristalsis, refer to the white arrow again, to cannulate the fistulous tract. Catheter cannulation of tracts directs the flow from the fistula toward the skin incision. The catheter placed in the intestinal lumen controls the bowel drainage by partially blocking the fistula and creating a low-pressure pathway, facilitating fluid drainage around and through the catheter shaft. The bowel perforation remains as a controlled fistula. One of the pigtail catheters draining the abscess will then be removed as the cavity is resolving. Notice that in this figure, when the residual abscess cavity is collapsed, the pigtail catheters are either reduced or removed. By this time, there is a walled-off inflammatory tract from the intestine to the skin. The catheter cannulating the fistulous tract is removed after 48 hours of keeping it closed. Once the catheter is removed, resolution is achieved from abscess-fistula complex. In this case study, the authors claimed this method was as effective in resolving abscess-fistula complexes without the need for surgery in most of the patients in this series. They suggest the sequential approach of effective abscess drainage and selective fistula cannulation as a technical guideline for catheter management of abscess-fistula complexes. That wraps our Part 3 lecture on catheter drainage procedure. Up next is our Part 4 video lecture presentation on surgical excision procedure on abscesses. We will talk about this procedure in detail, along with its billing and coding guidelines, as well as the documentation requirements published by CMS.